ready to go. Thank you.
Lovely, thank you, Kate, and welcome to everybody who's joining this afternoon's session on supporting the mental health of children and young people. My name is Alison Unstead. I'm the Deputy CEO of the City Mental Health Alliance, and we're really pleased to be hosting this event this afternoon. This issue is very close to my own heart. In January 2019, my then 12-year-old daughter was diagnosed with anorexia nervosa. It has been a very difficult and challenging time, but I'm pleased to say with the right treatment and support, my daughter is now in recovery and has been discharged from CAMHS. Now, there's lots of information and a support out there for parents and carers, and if you know where to find it. And I know today's session will be hugely helpful and informative. Just a bit of housekeeping before we begin today's session. This session is being recorded and the recording will be available to all attendees after the session. There will be time for questions at the end. Please use the Q&A function if you have any questions for our panel members today, and please use the chat function for any general comments that you have. But I'm afraid we will not have time to advise on any specific cases. If anyone needs any additional support, would like to talk to somebody, we do have mental health first aiders on hand, so please do private message Kate Laird, who is our event host today. So for today's event, we have a great panel lined up. We have with us Dr. Bruce Clark, who is the Clinical Director for Child and Adolescent Mental Health Services at the South London and Maudsley NHS Foundation Trust. He is a senior consultant child and adolescent psychiatrist with expertise in autism spectrum disorders, OCD, body dysmorphic disorder, ADHD, depression, anxiety, and behavioural management issues. Thank you, Dr. Bruce, for joining us today. We also have Professor Andrea Danese from the Institute of Psychiatry, Psychology and Neuroscience at King's College London. Andrea is a clinical scientist specialising in childhood trauma with expertise in child stress, anxiety and depression. Thank you also for joining us today, Andrea. And we also have Gabriella Wicks. Gabriella is the chair of the Mental Health and Wellbeing Committee at law firm Slaughter and May. Gabriella leads on Slaughter and May's holistic and proactive approach to mental health and wellbeing and will be sharing her lived experience with us today. So welcome to all of our panelists. So to start us off on today's session, I'd like to welcome Dr. Bruce Clark to open the session. Thank you, Dr. Bruce.
Thank you very much, Alison. So perhaps I'll just explain a little bit more about who I am. In fact, Andrea and I work closely together. So I'm the clinical director for services in South London and Maudsley, often just referred to as the Maudsley Hospital in South London. And we have a tight partnership between the hospital, the Maudsley Hospital, and the Institute of Psychiatry. So Andrea's one of my colleagues and fellow consultants, and we work in the Children's Centre at the Michael Rutter Centre, which is a large building on the Maudsley Hospital campus. We're actually the largest and most comprehensive children and young people's mental health service in Europe, and certainly the largest research entity in Europe and possibly in the world for children and young people's mental health research. So we're very, very much about researching clinical practice and taking it up to the next level. And so hopefully we'll be able to mention some of the exciting things that are going on and some of the ideas and things we're exploring and ideas that we have for the future. And I'll say a little bit more about that later. So we are a large department. We have just shy of 700 staff working in the Children and Young People's Service. So it is a very large team. And importantly, Andrea and I both work in what we refer to as our national specialist services. So 300 of our staff work in these highly specialist referral teams. So my own example, and again, I can say a wee bit more about this in a second, I run the only nationally commissioned NHS service for children and young people with OCD and related difficulties. So OCD and a type of OCD called body dysmorphic disorder that sometimes people confuse, and there is overlap with eating disorders. I can say a wee bit more about that later. So that's where my own area of expertise is, a very research active, clinically rich, highly specialist team thinking about OCD. And of course, the young people that we meet with OCD at a national service often have lots of other bits and pieces going on. Now, I'm going to change gear at this point just to mention we can't, of course, ignore COVID. You might have thought we're going to have an hour at lunch not to think about COVID just for once, but I'm not going to give you that opportunity, I'm afraid, because it's really kept me very busy as a clinical manager over the last year, as you can imagine. So if we wind back to last March, we went from running services as they had been, if you like, for many, many years to being given 5 days to close all of the inpatient wards on the Maudsley Hospital site. So that was an enormous, unparalleled undertaking. And we also had to shift in the same period of time to our usual being, 95% of the work that we did was face-to-face, to switching to 95% not being face-to-face. We had to, if you like, empty out the hospital to socially distance, like many of you guys will have had to do in your working lives in the corporate sector. And the reason I mention that is, of course, that's had a massive impact, but there's been some positive learning in that. We've learned a range of really exciting things about delivering groups, delivering therapy in a way that can be better. So my colleagues who work within eating disorders, who are real experts in lots of different types of group therapy and group delivery, have found that uptake and engagement with group work has actually been a lot better since they've moved to the online platform. So we are definitely taking away a number of key messages to think about how our reach can be improved, how our engagement with digital services and digital therapies, with future research plans, with investment, we can get those things right and build upon this experience. The counterpoint to that, of course, is the impact on mental health. I'll start with the clinical and then just say one or two interesting pieces before I hand over to Gabriella. So you'll be mindful that I've just said that we've moved to an online situation. That, of course, isn't always possible. We meet people who are in crisis, who are in our accident and emergency departments, or who really need that face-to-face touch. I think it's really helpful to remind ourselves that we are a hospital setting and we therefore have to comply with hospital level safety and infection control measures. We have wards now that are filled again and with very vulnerable people, elderly patients with dementia and who need a lot of care and support, and we have to do our utmost to keep COVID from our doors. The point I'm trying to make is that if you meet us now face to face, we are still mandated to wear face masks. And that is just in and of itself a big barrier to engagement. So it's actually quite interesting that in some ways, some one-to-one work is still better online because you can talk face-to-face and it can feel a bit more natural than sitting in a distanced room with face masks on, which is quite unusual. But if I extend that, I mentioned to you that I have some expertise in treating people with body dysmorphic disorder, which is a type of obsessive compulsive difficulty. It's common and it's where people are preoccupied with their appearance and they repeatedly and compulsively engage in checking and reassurance seeking and taking selfies and avoiding going out because of tremendous sense of shame regarding their appearance. And I'm left with a dilemma. In the last year, I've met clearly a lot of people with BDD, none of whom have been prepared to appear on camera when I assess them, none, because cameras are so pernicious and so difficult to manage for children and young people with image-related concerns. And if I meet those folks face to face, I have to try and deliver a psychological therapy where we want to help people expose themselves to the experience of showing their body, showing their face, and in an environment that tells us we have to wear masks at the moment. The very mask wearing in and of itself is a very interesting barrier to therapy. The patients I work with body dysmorphic disorder like wearing face masks, don't want to stop doing it, don't want those restrictions to move away. So I say those couple of examples just to highlight what an impact COVID has had in transforming the services, creating good opportunities and learning for us, but clear challenges. The last thing to say before handing over to Gabriella is, of course, we are a research-led hospital. We do huge amounts of research, and we, I think, did quite well in, sprinting from the start line. So one of my colleagues, Professor Breen, had a huge research group he was working with where they're doing very sort of fancy genetic research. But what he did was he had 100,000 people involved in that research, and he quickly sent them out questionnaires to ask them about their mental health. He was kind of looking at different things, but he used his population that were involved in his study, 100,000 people across the UK, and asked them how their mental health was doing right at the get-go. And he was one of the first people internationally to show an inverse relationship between age and an increase in mental health difficulties. In other words, what he showed was the younger you are, the more likely you were to see a worsening of your mental health in the context of the COVID pandemic. And we have followed that up with a really innovative, digitally led piece of research with every single one of the patients who is working with us at the moment, asking them questionnaires about their mental health as the pandemic has moved on. And because we are able to research that against what we otherwise know about people, their diagnoses, etc., they of course consent to that. We are learning a lot about how young people respond to their mental health challenges in the context of autism spectrum, COVID pandemic. I was thinking about autism spectrum because that's one of the key findings I don't have time to talk about right now. And so we are continuing to monitor, and it's just highlighted to us the power and reach that some of the exciting future research plans we have enhancing this new digitally enabled community. It really affords us some exciting opportunities going forward. So I hope that wasn't too much of a long-winded introduction. You can tell I get enthusiastic about things, but I think I'm going to hand over to Gabriella and you're coming back to me later.
Brilliant. Thank you so much, Bruce. So really good to be speaking with you all today. My name's Gabriella Wicks and I am a recovered anorexic slash bulimic. I don't really like the term recovered because it insinuates that, I don't struggle anymore and that part of my life is behind me. Instead, I like to describe myself as someone who has experienced the depths of an eating disorder and who has regained some balance and who manages thoughts and emotions daily. Every day is a choice. So as Alison said, I'm the chair of International Law Firm Slaughter and May's Mental Health and Wellbeing Committee. So I lead and shape the approach to mental health and wellbeing at the firm. And it's important to say that I didn't just fall into this role. I'm completely driven by personal experience, which is what I'm going to share with you guys today. And before I start, I just want to highlight that everyone's experience is unique, it's completely different. However, I hope that my story provides some comfort and some hope with whatever you may be experiencing in your own lives. So I'll start by saying that the interesting thing about mental ill health is that it often appears as harmless quirks. So my eating disorder, for example, started with a simple diet, but it wasn't long before that behaviour turned into a really dangerous behaviour that nearly caused me to go into cardiac arrest. looking back, it is nigh on impossible to identify the process, but somewhere along the line, eating turned to thinking for me, and that's the way it stayed for just over 7 years. And this actually continued well into my working life, where my eating disorder went entirely unnoticed, even though my behaviour had become increasingly bizarre. And therefore my focus at work diminished as well, and it was really replaced with anxiety, self-doubt, and it became increasingly more difficult to keep wearing that mask and keep hiding what was actually going on beneath the surface. I'll level with you all. The days were really, really overwhelming, and every day I would struggle to make really quite simple decisions. Do I eat lunch? Do I not eat lunch? How do I hide it if I wasn't eating? How do I sidestep lunch invitations with colleagues? And all these other excuses that came with it. My eating disorder really had quickly become my second job, and I really wasn't coping anymore. My physical health also began to rapidly deteriorate. It goes without saying, life like this isn't sustainable. Eventually, I was signed off of work, and I began to get the help that I needed, and I was diagnosed with anorexia. So after intense CBT, cognitive behavioural therapy, for over a year at the Maudsley, it slowly dawned on me how close the way that I was living my life had come to killing me. And I was really quite shocked, actually. My eating disorder was my coping mechanism. I was in control of it, surely. It wasn't in control of me. However, my psychologist at Maudsley, she informed me that I was undoubtedly one of the worst cases for a number of reasons that I'd seen at the hospital at that point in time. So my recovery began, and it continues to this day. I'd be lying if I said it didn't. At the beginning of my recovery, I realised just how much my personality had eroded. I'd become, my dad described this to me actually, a shadow of my former self. Like I was there, the lights were on, but no one was really home. That's how he described me when I was really suffering. And in order to go through recovery, I started to re-engage with some old interests. I picked up new ones as well. And this was a really pivotal point for me. I started playing guitar, singing at open mic nights. I started drawing again. I volunteered at a museum, history grad, had to happen. And I started to, get that, it sounds very cringy, but that zest for life again, something that I really hadn't felt for a very, very, very long time. And with that, I started to take off the mask. I started opening up to my friends, to my family, and I was met with unwavering support and love, patience. I have no words to describe actually what their support meant to me. In many ways, it saved me. And sharing my story like I am today has led me to opportunities that several years ago I would have deemed absolutely impossible. So I'm an ambassador for an eating disorder charity, Beat, and I'm a mental health speaker. So I speak about this stuff all the time. I'm really, really passionate about it, and I wouldn't be able to do that unless I had experienced it. So for me, it's every cloud has a silver lining. It led me to do what I'm doing today. Again, I'm going to level with you. My eating disorder, nearly did cost me my life. By nature, eating disorders are secretive. They're incredibly stigmatized. And we know how hard it is to ask for treatment. And it's even harder if a person doesn't meet the expectations of what a person with an eating disorder should look like. Eating disorders come in all shapes and sizes, and they are all equally deserving of help, support and, if possible, early intervention. So if I can, I just want to leave you with a few thoughts. If you're caring for somebody, if you're living with somebody, if you know somebody who's suffering from an eating disorder, as much as possible, and it is really difficult, but try not to focus on the physical. Eating disorders are inherently about emotions. Food, weight loss, weight gain is a byproduct. So talking and listening really is the very first steps that you need to be taking. Also, recovery takes time. And there are bumps along the way, if you will. I've had a number of relapses. It's all part and parcel of the journey. And it's got me to where I am today. There's no one size fits all. It's not always completely linear. There's a lot of peaks and troughs. And with support and listening and treatment, I do believe that there can be light at the end of every tunnel. You know, it's a very unique experience. It was a horrible experience at times, but it's had a really positive effect on, and it's made me the person that I am today. So when it comes to family, friends, carers, you know, who's supporting people, I would say that, you know, try not to give up on the person. You know, they're still there. They might just, you know, not quite be showing their personality. They may have disappeared for a bit, but I promise you, they are still there. I remember when I'd go to the Maudsley, it was every week I went to the Maudsley, I was an outpatient, and my nan would drive me, and we'd drive for about an hour all the way to Forest Hill, and she'd always see me off by saying, hey, there's light at the end of this tunnel, you just can't see it yet. And that is something that really got me through, and I wanted to share with you all today.
Gabriella, thank you so much for sharing your story with us, and for being so open and honest about your journey and your recovery. And just, you know, that light at the end of the tunnel, I think that's a lovely way to end the story with that positive message. So thank you very much. Bruce, if I can hand back over to you, please. Thank you.
No problem. I'd also like to extend you know, the thank you to Gabriella, because, you know, sharing those things honestly and openly is still, I have to say, sadly at some level, something that we need to do, because there is still so much stigma, isn't there, associated with things. And there isn't a person in this call. I often say this, if you're sitting in a room talking with people, there won't be a single person in the room doesn't have an experience, either themselves or a very close family member, of noteworthy mental health problems, and yet it still has that stigmatized feeling to it. So I'd really like to thank Gabriella, because it's just important. Things are getting better, but it is important that people just, you know, this is an ordinary thing. It's common. And if you think about other common issues like this, people don't hesitate to talk about, oh, I had my knee replaced, or, you know, I've got some problems with arthritis. It's just totally different. And it's very interesting. Now, Gabriella talked about her experiences of eating disorders, and I just wanted to say that where we work is constantly trying to innovate, and we do that because it's important. We have to drive forward mental health work, so there's a clear parity, if you like, in the way we deliver mental health treatments to what we know and how we can treat people with physical health difficulties. And so often that's lagged far behind, and it's really important in light of that we have to think about new ways to get treatments out there. I'm not for a moment going to pretend that the situation in terms of access to treatment is fair, equitable, or easy. There will be people in this call who have that very experience of the struggles to get into healthcare, and you do often have to fight in a way that's completely unparalleled for physical healthcare. you know, the government has a 5-year forward view, which is to rise investment in mental health services, and that they have managed to do that. But the ambition is still to get to the point on a journey where 35% of people with mental health difficulties can access a service. So we've still got a huge way to go if our ambition is to have a system that really doesn't offer an awful lot to people with 65% of the burden of the difficulties. And that fact as well highlights that the research that we, myself as a clinician, that Andrea as an academic needs to do is vital, because we won't get to the 100% by doing things in the same way and multiplying and just growing. We have to do things in a more tailored, individualized way, in ways that include the right kind of digital interventions and strategies. And so I just wanted to say a little bit about some of the exciting things we've got going on around eating disorders, and I'll say something about body image because it's of interest to me. So our eating disorders service is the largest in Europe and is well known internationally. Indeed, if you present in most North American hospitals, most insurers in North America won't pay for your service unless you're delivered Maudsley compliant treatments for eating disorder. And so we've been at the vanguard of rolling out evidence-led treatments for eating disorders for decades. And there are interesting things going on. We were given a lot of money with the support of Norman Lamb when he was a minister. He's now our Trust's board chair because of his passion for mental health. And he drove forward investments in our services, and we rolled out a national training program to ensure that each areas around the UK's level of skill in supporting eating disorder was lifted up from where it was. We've got a number of other things going on. We've developed, with the help of an academic colleague, Rachel Bryant-Waugh, a service within our eating disorders for something called ARFID. You've probably not heard of it. It refers to avoidant restrictive food intake disorder. These are people who have huge struggles with eating, not because they want to get thin or have concerns about body image. They might, for instance, be people with a learning disability or an autism spectrum that have sensory issues that relate to food, or difficulties with learning to swallow, and psychological anxieties about food and swallowing, or fear of vomiting. So a really mixed group of young people who, through different reasons, lead into difficulties where they avoid food to the point where it affects their health. Without that core, I'd like to lose weight or alter my weight. So we've got a lot of work going on in that. Rachel has advised the World Health Organization. ARFID is now recognized internationally as a thing that needs research and clinical innovation. And we have the only service in the UK reaching out to those sorts of young people. We're trying something called cognitive remediation therapy within our eating disorder services. So this is a very interesting cognitive technique led by Professor Kate Centuria and others, where we try and tackle some people with eating difficulties have a particular rigidity or cognitive inflexibility. And we can deliver and tailor programs that help them train up their brain to be a bit more flexible, thinking laterally. And the plan is to attempt to do that, and it's been shown to have some positive benefit in eating disorders, to free up your mind, if you like, to get you ready for therapy. So my team are planning to do that and apply that for people with obsessive compulsive disorder, to see if this sort of neutral training program, where you get to see and think about things in a more lateral thinking way, can facilitate you opening up to a psychological therapy for a range of different conditions. So that's quite an exciting field. I'm going to say just a little bit about body dysmorphic disorder. I told you this was a common disorder, and it's an important one that's sadly been poorly recognized. And it's very common in teenagers in particular. So this is the condition, body dysmorphic disorder, where people have intense, preoccupying, if you like, obsessions about their appearance, very negative experiences of their face, their skin color, their nose, or whatever, and it leads them to compulsively and ritualistically, as I said before, seek validation, checking in mirrors, doing selfies, spending hours and hours looking in the mirror, and importantly, avoiding social situations, schooling, work in adults, having a huge impact. And it is so associated with a very, very, very high level of suicidal thoughts and behaviors. So if you look and follow up people who have body dysmorphic disorder, by the time they get to adulthood, very sadly, a half of those people will have made an attempt on their life. Now, we took this and tried to understand how we treat people early, and my team in the Maudsley Hospital was the first in the world to do a randomized controlled trial where we took psychological principles and developed a therapy, and we showed good outcomes that we do and can get efficacious, positive outcomes for these people so they can get their body dysmorphic disorder under control during childhood. And we've continued to follow that up. So I love working with OCD. I often say it's the most treatable mental health condition. It's just sad that people often don't get the right treatment, and the commonest mistakes are made over and over. So with BDD, we hoped to get there. That first randomized controlled trial didn't show the same size of effects, but we've tailored it and refined it, and we've kept looking, and we're partnering with colleagues internationally. We do a lot of work with the Karolinska Institute in Sweden and sharing our data. And we've now got to the point where with body dysmorphic disorder, we can expect the same kinds of outcomes that we see with other types of OCD. So we're able to get 80% of people with one course of therapy putting their body dysmorphic disorder behind them. And that's enormously important given how impactful it is in terms of suicidality and impacts on life. Now, I mentioned earlier that the commonest mistakes are made time and time again, and we're looking through, when we move to our new centre, the Pears Maudsley Centre, we want to do more education. We want to continue this effort to help people nationally, learn from what we've learned, improve practice. And so we want to do things like fundraise for additional training programs with proper ongoing supervision. We also have a really exciting program we'd like to deliver across primary schools. We have lots of stuff that we do out there in the schools and our local communities and around the UK, in state schools, in private schools. We're out there doing things to help kids with anxiety and low mood. But we've got a new program we're going to try and fundraise for called Me and My Body, which will get in to kids early during their PHSE curriculum before they develop any difficulties, and just teach them healthy lessons about their body and eating, and their body and self-image, to really hopefully research, is that an impactful thing to do? Can that reduce the propensity for people going on to develop eating difficulties? Now, I've kind of talked about one or two of our teams. We have 20 national teams with all of this exciting research, which when we move to our new centre, my colleagues like Andrea, who do his clinical sessions in the building, and myself, who's there the whole time, will be located together. And that, synergy of having us together all of the time, and the investments that we've had to do more research, we really hope are going to take things to the next level. You can see I'm a waffler, so I'm going to let Andrea speak. Alison, do you want to hand over?
Yes, please. Thank you so much, Bruce, for that. And it is incredibly exciting the work that you're doing, and obviously the work that you will be doing in the future with the centre. I'm also pleased that you referenced the work that you'll be doing with schools. That's a couple of questions we've already had about the interaction with your work and that of schools. So thank you very much for telling us about that. So yes, so Andrea, I'd like to hand over to you now. I know you're going to talk us through some of the conditions and managing emotional symptoms. So over to you. Thanks very much.
Sure. Thank you, Alison. And again, thanks to Gabriella as well for such a strong and powerful account of her experience. Yeah, so I want to tell you about my job briefly, and part of my work involves leading a team of clinical and non-clinical scientists who are trying to understand and prevent the detrimental effects of childhood trauma. Because we believe that childhood trauma is really one of the key modifiable risk factors for poor mental health later in life. We use neuroscience and genetic methods, as well as large international cohort to carry out our investigations. And our research has informed several national and international institutions, from the UK House of Commons to NSPCC, WHO and UNICEF, on how we understand the experience of trauma in children and how we can support children after these experiences. But like Bruce, and like Bruce was saying, I'm also a clinician, and another part of my work, therefore, involves leading another of the Maudsley flagship national and specialist clinics. And particularly, that's the one that focuses on trauma, anxiety, and depression. So our clinical work really focuses on supporting children and families where the young people have generally treatment-resistant or very complex cases of PTSD, anxiety disorders, and depression, and often to avoid or reduce the length of inpatient admission, and therefore improving outcomes for young people, families, but also for services at large. We work with difficult to treat cases across the UK and internationally, and therefore we were one of the few teams that already before the COVID pandemic and lockdown were using quite widely video links like we're using today to make assessment and also to deliver treatment internationally. And in addition, we have worked with the UK government to plan and run screen and treat programs in response to the terrorist attacks that the UK has experienced in the past few years, and therefore supporting young people and families at those critical times. So this work is of course, to us extremely important, but increasingly we are becoming aware that this is really only a focus on the most severe end of a whole spectrum of psychopathology for young people. Really just the tip of the iceberg in what we can, and I feel increasingly should be doing. And therefore we have become increasingly more interested and concerned about the hidden and larger portion of emotional problems and symptoms that we cannot see in the clinic. So our focus is shifting from this hyper-specialist treatment that we have been providing to more universal forms of support and education around emotions, with the understanding that if we can get better at coping with normal emotions such as anxiety, sadness, or anger, we can improve the well-being and prevent psychopathology in the population. So the idea is really that we can shift the emotional well-being of young people, and therefore there will be fewer young people that experience the most extreme forms of emotional distress, and therefore will require more direct clinical support. So the crisis brought by COVID, of course, has only catalyzed this work and has kept us very busy over the past year. And what I thought of doing is just to give you a very brief overview of some of the work we have been doing in this area over the past year. The first one that we have been engaging with was actually work that we have done with BBC Bite Sizes, that is a very good resource of tips, very practical tips on how parents can support their children through these difficult times. And I was asked to give some example of the kind of suggestion that we might give in those contexts. And so I wanted to refer to a couple of ideas that perhaps are less commonly discussed. One is about calming techniques. So for example, we were advising about a specific type of calming techniques that has a very strong evidence base in the clinic. So what we're doing, you see, is always trying to take what we have learned from the clinic and we know works in the clinic, and think about how we can communicate and empower parents and adolescents, as I will tell you in a minute, to use more widely. So this type of calming techniques is called grounding. And the principle is that strong emotions tend to be about the past or the future. And what grounding does is to help us to use our senses to bring us back to the here and now. So the advice is that when we have these strong emotions, we can use our senses and think about 5 things we can see around us, 4 things we can hear around us, 3 things we can feel around us, 2 things we can smell around us, and 1 thing we can taste around. And so by really engaging our senses, we can come back to the here and now and abandon, in many ways, those strong emotions. Another point that is quite important to us is that of reflecting and learning. So the idea being that it's really hard to think clearly when we experience strong emotions. And therefore, it's important to help children and young people to consider their feelings, their thoughts, and their behaviors once they're calmer, once they're in a calmer place. And this can help them to think about other ways in which they could have coped with the situation, and other ways in which they can behave towards themselves and others. So learning to be kinder. And over time, that can also help them notice early signs of strong emotions so that they can more quickly and effectively use coping strategies before things get out of hand. So these are the kind of very basic and practical tips that we have implemented initially with the help of BBC. But we also thought that parents, particularly during the pandemic, of course, were incredibly busy. They were doing several jobs, right? The day jobs, they were parenting, and of course, at that point, many of them, as we know, they were really feeling as if they had to be much more careful and mindful of their children' mental health and well-being. And therefore, we have created, with new collaborations with a creative studio here in London, in the midst of the first lockdown, so trying very quickly to get funding and pull together new strategies, a set of very entertaining animations that deliver these tips in ways that are more accessible and enjoyable and fun. And in fact, we were also able to to join a set of very famous parents that were kind enough to narrate the animation for us, and therefore make this even more enjoyable. And these have been not just widely distributed in the UK through television, but also in other countries. So we have adapted them and have translated them, and they're now distributed widely in Australia and Germany, and we know other countries are also trying to do the same. And this is just some of the examples of the work we have been doing, and many other colleagues have been doing at the Maudsley, to work with young people and to work with schools, particularly in primary school, to really develop emotional resilience. The latest of these projects, the one being the latest, probably the one that I'm most enthusiastic about right now, is really the work that we have been doing directly with adolescents, with the idea that, of course, addressing emotions, emotional symptoms, and emotional disorders in adolescence is as important as it is difficult. So on the one hand, emotional disorders are the most common disorders overall, have increased in prevalence over the last 2 decades and affect adolescents particularly much more than children. On the other hand, of course, if you are parents of adolescents, you know that the delivery of messages to adolescents has to be very carefully crafted. And so we have really worked and built yet a new partnership with not just creatives, but also social media experts to develop and disseminate this information. And so to maximize engagement, for example, of the psychoeducational material, we avoided drawing lines between normal and abnormal behavior and instead talk about universal experiences of emotions, as I mentioned before, that are familiar to all of us, such as anxiety, sadness, and anger, and really thinking about how we cope with those basic emotions. We consider that adolescents cannot be treated as passive recipients for expert advice, and therefore we really involve them in co-production of the material that was targeted to them to find effective ways to engage their developing interests and preferences. And finally, as I said, we have joined forces with social media experts with the idea that particularly adolescent with emotional symptoms may be withdrawn, socially isolated, and difficult to reach overall. And so a challenge that clearly was only made worse during the pandemic. And therefore, by joining forces with the social media expert, we're able to disseminate the material through media popular with adolescents, so the social media, and have had so far fantastic feedback and engagement from them. So overall, we really have, through these projects, tried to learn new ways of working and try to find strength from a bleak year.
Brilliant. Thank you, Andrea. That was fantastic. And I have, with my daughter, used some of those distraction techniques, and I've got to say they're incredibly helpful. So thank you for sharing some of those today. I'm conscious we've got 12 minutes left for the session, and there's been some really good questions that have come through. We've had some questions sent in advance as well. So I'm going to put the first question to you, Bruce. And this is about whether you have any tips for parents on how to positively support children's mental health. So what to do, what not to do. And I'd like to link this to a question that's come in this afternoon about self-harm, if I can, in relation to cutting. And how do you get to understand the reason for this without interrogation? And how does this benefit the teenager? So I think perhaps if there's anything that you can share around strategies for parents in helping children who may be self-harming.
Right, it's quite a broad topic because, you know, how you help an individual kind of depends on the age or the type of difficulty that you're speaking to. So it goes right from, you know, Gabriella, for instance, mentioned BEAT, that is a national high quality organization around eating disorders. Some of those charity partners are really great sources of good quality information and contact in the world I work in. OCD Action, OCD UK are two really profoundly helpful charity organizations, National Autistic Society. They offer a huge range of things right through into the community through drop-ins and so forth. And so there's a huge range of things out there. It's hard to know how to navigate them. Sometimes school counselors, GPs, sometimes they can, sometimes they can't help you navigate some of those things. You can also look at some reading. The difficulty with reading and support and self-help manuals is they're not necessarily brilliantly researched. So in the world of anxiety, the huge book of worries, Virginia Ironside's books often used. A colleague of ours, Ulrike Schmidt, published a book called Getting Better Bite by Bite, which was good because they actually took the care to research whether it makes a difference. Most people don't do that. And that Ulrika and Janet Treasure, who wrote that book, evidence that, you know, reading and engaging with the material in that makes a difference. Ditto, Breaking Free from OCD, our team's book about OCD, can make a difference. Now, in terms of self-harm, there are organizations out there that can help. I have to say, if someone's self-harming, you do need to be starting to think about, you know, asking for some extra support. But most self-harming that happens, of course, is not attached to suicidal thoughts. Most people who self-harm do so, if you like, as a maladaptive grounding strategy. They're doing it in response to stress. That is the commonest reason that people engage in self-harming. And you do need experience to be able to open up those sorts of conversations. And that can be super tricky to handle as a parent, because the reasons that sit behind why someone's self-harming, the stresses that lead to that, can be, you know, manifold and need careful thought. But if you are a parent and someone discloses those things to you, I think it's good to allow and facilitate that young person opening up and telling their story, not interrogating them, because I guess if you're not experienced, you won't be asking the right questions. But I think keeping a very watchful eye if someone's self-harming, and I think having a very short fuse, if you like, to going and asking for some extra support, be it, you know, flagging it through school counselors, or the general practitioner. So I can't really do huge justice in a short answer to how do you support someone who self-harms, because it's what we do a lot of the time, and it isn't simple.
No, of course, but thank you for that, for that response. And you know, I'm sure there's lots of information and advice out there for parents who may have any particular concerns. Just moving on to another two questions actually relating to social media. So Andrea, if I can perhaps ask you to respond to these. I know you talked about the benefit of engaging with social media in terms of getting some of the messages and increasing engagement. But we've had a couple of questions in actually around whether the use of social media has been studied in terms of links to some of the negative effects, and perhaps potentially around the body dysmorphic disorder, but also around, again, self-harm has been referenced here. So I wonder if there's been anything that you can talk to on the impacts of social media.
Sure. And we have a couple of hours, right?
Unfortunately not. Unfortunately not.
I think there is much that has been done, and comparatively little that we do know about social media and mental health. I think there are some very important concerns about the use of social media. I was just thinking about Bruce and what he was telling us about body dysmorphic disorder. And of course, there will be concern, particularly in that area, right? There are many concerns about social media use as well in areas that are closer to my expertise, for example, in terms of cyberbullying. Cyberbullying is something that has been a concern for several years now. And I think at the best of our knowledge right now, that remains a concern. But we also know that what happens in the virtual world, in many cases, also happen in the real world. So what social media does is amplify the experience that is already there in the real world, if you like. The other broader question is related to the duration of social media use, the amount of engagement, and mental health problems. And there the relationship is much more unclear to see based on the data that we have currently. There is a lot of data that is cross-sectional, so it's a snapshot, and shows that the more young people use social media, the more mental health distress and disorders they might have. But the longitudinal data that actually can tell us whether one comes before the other and therefore might be a cause of the other is much less clear. And so it's possible, absolutely, that for some young people, the experiences are very negative, and more engagement with social media leads to severe mental health problem even. But in other cases, it will be, for example, the isolation, the loneliness that brings people to use more social media, and therefore is a byproduct of already having mental health problems. So, and those are many negatives that have been studied and discussed about social media use. But I do think that there are also a number of opportunities that we're just really starting to understand and hopefully use in the future. So it's something that can have negative consequences. We need to definitely keep an eye on, but we also need to better learn for its potential.
Brilliant. Thank you very much for answering that. And Gabriella, to you, you know, there will be many parents listening today who may have a child who is struggling with their mental health, and undoubtedly themselves will be struggling to manage some of their feelings. I mean, is there any sort of a last sort of message that you'd like to say to those parents?
Yeah, absolutely. So a couple of points here. Number one, your feelings and your emotions are really valid and they're really important. It's so normal to experience guilt, anger, frustration, and even, you know, low mood yourself as a parent or a carer. I spoke to my mum about this at the weekend. I went to go and see her and I said, I'm doing this event. What have you got any, you know, kind of insight into how you felt? And she said, I just felt awful. I felt helpless. I felt overwhelmed, and I didn't know how to help. I wanted to help, but I didn't know how to. And so I would really recommend looking at Beat and Mind's resources around carers and parents in particular. So I guess my message to you is that it's natural and completely understandable to feel that way. And the person you're looking after, or who, you know, whoever it is in your life, you know, they still love you and they still care about you. They're still their old selves behind the disease, and it is a disease. You know, it's really hard to see, but I promise you that they are there. And also know that, you know, your loved one will realize on some level the frustration and the stress and the sadness that they are inflicting, albeit they don't mean to, but they are inflicting on their family and friends. And trust me, speaking from experience, they will be beating themselves up about that on the daily, because it's awful to think that you're putting the people you care about through something like that because they care about you. Two more things. So I would really, as a practical point, encourage whoever you're caring for or living with, or, you know, whoever they are, to speak their truth. And what I mean by that is to encourage them to say what they're actually feeling as much as possible, to allow whatever they're feeling on the inside to match the outside. So when I shared my story, I said that I would often hide behind a mask, put on a smiley face, actually giving somebody permission to say, you don't have to smile today. If you want to stay in bed and mope around, you do that. Because if that's how you're feeling, then that's okay. The more you encourage somebody to do that, the better. They'll be more honest with you, because as I said, particularly with eating disorders, they can be very stigmatized and incredibly secretive. So truth is really important. And then last but not least, I would say really try and re-engage with the person behind the disease. You know, engage in their skills, their interests, their hobbies. Because for me, and this is a personal experience, I was defining my self-worth from weight loss, from how I looked, what clothes I fitted into. And I had to really redefine what I considered worthy about myself. So for example, I got back into art. I love drawing, and I got back into it. And in order to draw, I had to eat, because when you don't eat, you shake and you can get a bit jittery. And so I had to eat in order to draw. And I set myself a goal to get as many pictures done as possible. I think I tried to do like 10 or something. So I was working towards that, as opposed to restricting or looking at what I was eating that day. And finally, it's not a linear journey. It's filled with peaks and troughs. And even if you do go through relapses and you go through really difficult periods, it doesn't mean you are moving backwards. I've said it once and I'll say it again, there is a light at the end of this tunnel, whatever tunnel you may be in. You just may not have reached that light yet, but I promise you it's there.
Brilliant. Thank you, Gabrielle, and thank you for those really practical tips as well. So just like to say thank you to our panelists. It's been a great event. I've learned a great deal from today. I wish we did have a few hours to talk about all of the different issues, and I'm sorry that we have been unable to answer everybody's questions today. We will be sharing a resource with the video, the recording of today's event. So there is a lot of signposting to wonderful resources and tools and things that are incredibly helpful. But to close, I'd just like to hand over quickly to Bruce just to tell us a bit about the Pears Maudsley Centre. Thank you. Oh, you're on mute.
the phrase that's been said more than any other in the last year. So yes, thank you for handing back to me. We've touched upon some really interesting stuff, and so apologies for running just a little bit over. I think it reflects ours and people joining us as enthusiasm for the area, and some of the questions have touched upon areas where we really need to do the research to improve services and to better understand. So we've been talking about the fact that I'm at South London and Maudsley, and Andrea is employed by the King's College London at the Institute of Psychiatry and Neuroscience, and we are coming together. We've started pile driving. We're building our new centre, the Pears Maudsley Centre, and it's going to open in 2023, and it will give us the space, the capacity, and some of the investment that we need to take things to the next level. So we're drawing together all these key scientists, clinicians, and educators from around the UK and around the world to really help take things to the next level. And we've been super lucky. There's somewhat of a zeitgeist in this area to think about and get behind improving services for mental health. We've already had some overwhelming, really fantastic, generous donations. And so I want to share a short video with you about the background of the centre and its need and the vision. There's a ways for us to go. We're still looking for further support and resource. So if people want to run the marathon for us or do anything else to support us, we really, really welcome you getting in touch. And so some of the information about that is going to be in the resource pack. So I'm just going to finish by allowing colleagues to queue up and share the video.
Lovely. I'm just sharing the video now. Do put it in the chat if you can't hear it. Here we go.
Depression kind of takes a hold of you. It's like a big monster, and it's like trying to defeat you, take every bit of you out of yourself.
Because like when you self-harm and you see the blood come out, it's like all the pain is coming out of you, and then the next day it just all comes back.
We know that approximately 70% of mental health problems will have started by the time that a person reaches young adult life. The key to making fundamental differences to our society's mental health issues is to intervene early. The new Centre for Children and Young People is going to be a brand new purpose-built setting that's going to bring together the world's leading clinician scientists and researchers working in mental health from conception through into adult life.
So by co-locating people side by side, those conversations about what can science do to address clinical questions and what are the important clinical questions for scientists to be asking will be part of what happens on a day-by-day basis.
The benefits include improving and understanding mother and baby mental health, thinking about treatments for young people with OCD, for example, supporting new treatments for autism so that children can have a much better quality of life, supporting and preventing young people with eating disorders and finding new treatments for that, finding new digital technologies that we can use. So really a whole suite of new treatments and new research that will really transform the lives of young people who have mental health problems.
I think the way the new build has been designed with the terraces has really shifted the view of what mental health services look like. It's really open, it's user-friendly, it doesn't look like a psychiatric hospital.
We met with groups of the young service users to inform what we do as a design. They felt that the places they were visiting were like institutions that closed them in, disconnected them from real life. So access to external space was a huge one, and being close to nature. So all of the findings from those workshops are currently going into the scheme that we're developing.
Sophie was first diagnosed with OCD when she was 9 years old. We were at the point, the whole family, of thinking this is how life is. Sophie was so ill, it was almost like she'd given up hope. We really couldn't believe that she could be cured and she could live a normal life again. And her life basically was saved by the team.
To date, research often takes many years from those earliest ideas to everyday, practical, translated and published findings that can be taken to scale. This centre will halve the time that it takes for that translational pipeline.
I'm always hopeful that it will be something that I won't have to struggle with anymore. By the time you get to where people are in inpatient services and stuff, it's kind of too late. The earlier you can catch a cancer, the less it spreads. I think it's the same with mental health.
We want to make a huge shift at a societal level. People will look to see what we've done and it will set a worldwide example.
So please help us transform the lives of children and young people experiencing mental health conditions.
Yeah, just to say thank you to everybody for joining us this afternoon. Enjoy the rest of your day. Thanks very much. Bye-bye.
Thank you.